As we explore the professional issue of autonomy in nurse anesthesia practice, we will outline the strengths, opportunities, weaknesses, and threats this issue brings to our profession. We will do this by providing the historical context to the debate of the nurse anesthetist's ability to provide safe, autonomous care. Next, we will explore the nurse anesthetist's ability to obtain autonomy. Then we will discuss the cost of anesthesia, taking into consideration provider costs with relation to salary, anesthesia practice model, and training costs. Last, we will explore the comparison between anesthetists and CRNAs with regards to safety and quality of care.
Anesthesia in the late 1800s was a dangerous prospect for the patient. Oftentimes, the task of providing anesthesia fell to the most junior physician, an intern, who was more interested in watching and learning from the surgeon how to perform the surgery than actually focusing on the patient. Additionally, for practicing physicians, this role of anesthesia was underpaid, if not times unpaid. And as a result, many patients were dying from overdoses of ether and chloroform. So at the time, surgeons and patients wanted to find a new anesthesia provider, and that was the inception and origin of nurse anesthesia. Nurse anesthesia originally got their start from Catholic organizations and Lutheran organizations of sisterhood of nuns that were also trained nurses and that were used in religious orders and hospitals to provide anesthesia where they did not have interns or physicians simply did not want to do the job. And what they discovered was the patients stopped dying because the nuns were actually focusing on the patient rather than learning the procedure for themselves. One of the most notable organizations, although secular herself, was Alice McGaw, who was the anesthetist for Dr. Charles Mayo and Dr. William Mayo, who was later described by Dr. Charles Mayo as the mother of anesthesia. And you can see her in this photograph to the right here. Like the Mayo Clinic, there was another program at Lakeside Hospital near Cleveland, Ohio, that was training nurse anesthetists, starting with Miss Agatha Hodkins. She, like Alice McGaw, received training on the job and was revolutionizing the practice of anesthesia with over several thousand surgeries performed with no anesthetic depth occurring. And this attracted a lot of attention at the time because anesthesia was thought to be one of the main killers of patients, and anyone who was not killing the patients with anesthesia was regarded as doing the right thing. And with this came surgeons sending their nurses to become trained by Agatha Hodkins at this Lakeside Hospital. And essentially, you had the development of the first nurse anesthesia program in the country. In World War I, the Lakeside Hospital formed a Lakeside Volunteer Unit. It was an ambulance company under the Red Cross and traveled to Paris and began to receive war casualties. As you can see here, some of these are the photographs from the Lakeside unit with Agatha Hodkins in the corner here with some British and Canadian forces. And later on, when the United States did enter the war, nurse anesthetists were used not only in training of other host nations and coalition nations, medical forces in the use of anesthesia, but they're also forward deployed, working autonomously at the front line and in very close proximity with the enemy and handling hundreds and hundreds and hundreds of casualties at a time. As a result of this wartime trauma experience and anesthetic, nurse anesthetists gained high regard among coalition partners and respect from not only their surgeons, but also respect back home in the United States of America. This, of course, caused severe consternation with the physician anesthetists that were slowly developing their practice at this point, once they realized there was somewhat of a lucrative market now to be made in anesthesia. And as you can see, became a huge issue in legal trials in the United States to determine whether nurses were illegally practicing medicine. So one of the first cases happened in the great state of Kentucky, where the Kentucky Society of Physician Anesthetists brought a case against a nurse anesthetist who they thought was practicing illegally. That anesthetist's name was Margaret Hatfield, and they found the contention was that she had no right to be doing what she was doing, and this was the sole province of physicians who are specialized and trained to provide anesthesia. And the appellate court, when they wrote their verdict finding in favor of Ms. Hatfield, said that although physicians are a learned profession, giving the sole realm of anesthesia over to physicians only would be invading the province of professions of not only pharmacy, dentistry, and trained nursing, so that anesthesia itself did not belong just to physicians. Another significant case that established the practice of nurse anesthesia in this country occurred in the 1930s in Los Angeles, a case of Dagmar Nelson, who was an anesthetist that worked at the Mayo Clinic and was invited by one of her colleagues, a surgeon, Vern C. Hunt, to come practice in California. And the physicians in California were not happy about this happening, so they brought, again, very similar to the case in Kentucky, a case to the medical board saying that she was practicing without a license. And after some deliberation, the defense's argument of Dagmar Nelson was that giving drugs under the direct or understood instruction of a physician was a recognized practice within the limits and definition of nursing. Reporting changes in the patient's condition and acting accordingly under direct or understood of supervision of a physician was in the province of nursing, and nursing education accepted by law gave instruction in the administration of anesthesia and recognitions of signs and stages of anesthesia was an established practice within the registered nurse to give anesthetics as nursing duty. And the court therefore completely agreed with this and found that as long as there was a physician, be it either a physician anesthetist or a surgeon somewhere present, or someone having oversight over the nurse anesthetist, such as a physician on staff who agreed with the treatment plan of this nurse anesthetist or had a practice agreement and knew the skills of the nurse anesthetist, she was not, or he was not, in fact, practicing medicine, but actually in the province of nursing. And this had important implications for much of our practice, being tied to certain states in the union that actually require nurses to have some form of supervision by a physician, be it anesthesiologist or surgeon.
One of the more compelling threats to autonomy is the concept of autonomy itself. That is, as its name suggests, auto from the Greek word for self and nomos from the Greek word law, hence the ability to govern oneself and one's profession. Critical to this determination is the concept of profession. Do we, as nurses, have a profession? And secondly, does the role of the advanced practice nurse, specifically that of the nurse anesthetist, constitute a profession under the auspices of nursing or medicine? Well, to answer that, we need to really understand what is a profession. In the vernacular sense, it is simply one who makes his or her living performing some kind of occupation. Thus, the distinction between Tom Brady as a professional athlete and an amateur is that the former earns his living from his athletic prowess, whereas the amateur is dependent on some other form of physical means of survival. Clearly, this definition doesn't really help us in nursing, but it does lend to the indication that there's actually a richer definition beyond the notion of profession in a vernacular sense. So what is that? Profession as defined by Webster's is a calling requiring specialized knowledge and often long and intensive academic preparation. This definition, too, is wholly inadequate to encompass the nuanced meaning of what a profession is in the comparison of a profession to medicine, law, or education, but it does provide some substance, unlike the regular or vernacular definition we spoke of in the last slide. Critical to this is that academia is an integral component. If we investigate this further in the medical literature, there is really no agreed definition of what a profession is. Yet, nearly all of these definitions begin with a 2 or 3 sentence description of profession that contain the common elements. That is, a work based on a command of complex body of knowledge, that there is some kind of service to someone other than the organization itself, so an outside of the organization, and an autonomy, the concept of autonomy itself, which is sometimes linked to its self-regulation. In examining this first element, the mastery or command of knowledge, nursing did not always have that strength of knowledge as the foundation, as the evolution of nursing began with very humble beginnings. Initially, it was the responsibility of the wife, the daughter, and the family servants to take care of their hospitalized family. This followed sort of patriarchal norms in society, and nurses initially were no more than formalized surrogate family members at hospitals. And in many countries today, this continues, even in industrialized nations such as Russia, where family members are expected to provide day-to-day care, clothing, bathing, feeding, and exercise to supplement what hospital nursing care is provided. In the 1800s, most medical care did not take place in hospitals, rather took place in the individual's home, and the truly sick were refused admission at voluntary hospitals. And this sort of began the critical debate of how to differentiate between nursing work and work done by nursing. Certainly the most sentinel development of nursing is credited to Florence Nightingale during and after the Crimean War. Not only did she provide some outrage based on the level of care that was provided during the Crimean War, but this afforded her the ability and political leverage to formalize the nursing knowledge and the transformational efforts in nursing education. The Nightingale School of Nursing, which she instituted, began a model that was replicated in the United States, and in 1873, the New York City's Bellevue Hospital became the first in the country, with another 400 training schools for nursing opening over the next 25 years. Certainly over the ensuing century, this idea of nursing occupation and knowledge has risen from its humble beginnings to one where there is a clearly defined educational process and a requirement for the study of this occupation. This would then suggest that, at least in this facet, nursing, and by extension CRNAs, have achieved that level of component of that professionalism. As alluded to, nursing began to serve in hospitals under a specific level of knowledge that was trained. And so this service to society concept, which is one of the other elements of determination of a profession, is certainly met in this aspect. Nursing has a commitment to competence, integrity, and morality, altruism, and the promotion of the public good within their domain. And this can be demonstrated in the public declaration of almost every nursing organization, including the Code of Ethics for Nursing from the ANA, the Professional Practice Manual for the Certified Registered Nurse Anesthetist, in addition to every state's nursing practice acts. These legislative actions of these individualized states sort of buoy the argument that the public must believe that its interests are served best by state licensure or by other equivalent methods of eliminating those entrants coming into this profession or into this occupation. This substantiates that there is a service to society and the public believes in this service to society. The final facet of this definition of profession is autonomy. Autonomy has been defined as the quality or state of being self-governing, as we mentioned earlier. More specifically, though, autonomy is the capacity of an agent to determine its own actions through independent choice within a system of principles and laws to which the agent is dedicated. Although nursing has advocated itself as a profession since the early 1900s, this critical aspect of autonomy remains a steadfast barrier into attaining this outcome. Although nursing regulates or self-governs within the auspices of its occupation, as a profession, it lacks the ability as an agent to independently provide care to patients through their own choice, as medical care is regulated by physician oversight and orders. Physicians have been adamant that the occupation of nursing is a paramedical division of labor, that, quote, occupations which are subordinate members of the medical division of labor, however they call themselves and are frequently called by others as professions, of which nursing is perhaps the most prominent example, they are clearly marked differently than medicine. For while it is legitimate for them to take orders from and be evaluated by physicians, it is not legitimate for them to give orders to and to evaluate physicians. Without such reciprocity, we can hardly consider them equals of physicians, end quote. And so nursing often commonly confuses autonomy with the related concepts such as authority, accountability, power, professionalism, and independence. So how does this threat to autonomy as a profession fit with nurse anesthetists? Well, nurse anesthetists are different. Although nursing may lack the clear autonomy of practice, the nurse, specifically the advanced practice nurse, or CRNA, does possess that level of autonomy. They have been provided with the ability to independently practice or licensed as such by states and practice both autonomously and in collaborative models. In legal challenges, nurse anesthetists have been clearly demonstrated to provide independent care and that nurse anesthesia was not the illegal practice of medicine and that anesthesia was performed by a nurse was nursing. Thus, CRNAs live in a duality, being both part of an occupation, which is nursing, and a profession, such as an advanced practice nurse.
When one looks at autonomy of nurse anesthesia, one must analyze the societal cost of anesthesia. This is complex with multiple components that, when added together, show the true cost of anesthesia. There are three major components to true anesthesia cost: the cost of the hospital or facility, technology costs, and provider costs. We will only be analyzing provider costs with relation to nurse anesthesia autonomy. Hospital provider costs include salaries. Anesthesiologists make approximately $240,000 per year versus the CRNA, who makes approximately $150,000 per year. This discrepancy means that a hospital could hire 3 CRNAs for the cost of 2 anesthesiologists. This is significant when hospital budgets, costs for training, and manpower are considered. Reimbursement for services provided is also a contributor to provider costs. This depends on the anesthesia delivery model, which will be discussed in the next slides. Professional training is also another significant cost when considering provider costs. This too will be discussed on future slides. The anesthesia delivery models are important when considering the cost of anesthesia. They often depend on the hospital or can be dictated by state laws or regulations. These models vary in degree of autonomy in which CRNAs can deliver anesthesia. There are 4 basic models: the anesthesiologist only practice model, the medical direction model, in which one anesthesiologist oversees 1 to 4 CRNAs, the supervision delivery model, where one anesthesiologist oversees greater than 4 CRNAs, and the CRNA independent practice model. Each model has an impact on the amount of reimbursement eligibility and cost effectiveness to the hospital. Medicare has specific requirements for reimbursement depending on practice model. For example, Medicare reimburses a non-medically directed CRNA service at 100% of the anesthesia fee, but a medically supervised CRNA is only reimbursed at 50%, with which the anesthesiologist is also reimbursed based on the complexity of the anesthesia care. This discrepancy is significant when hospitals, especially rural hospitals, are considering practice models for reimbursement, and is one of the weaknesses facing the issues of nurse anesthesia autonomy. Researchers have analyzed the cost effectiveness of several anesthesia delivery models. They determined that independent CRNA practice model is the most cost effective and is the only financially sustainable model, especially in a low demand market. All others, unless in a stable, high demand market, were non-sustainable without subsidies. They also found that in a high demand market, a supervision model of one anesthesiologist to 4 CRNAs can be cost effective provided demand remains stable. This implies that autonomous CRNA practice is the most cost effective and would be the best choice for cost containment strategies in a rural medical community. Cost-effective rural health care is one of the important opportunities in the argument for autonomous nurse anesthesia practice. These practice models support a reduction in the total cost of anesthesia and are significant strengths for support of greater autonomy in nurse anesthesia. The length and economic cost of training is another important aspect to be analyzed in conjunction with CRNA autonomy. There is a vast difference in training, with the financial burden of training being greater for anesthesiologists. This has a societal financial impact on the expansion of anesthesia providers. Education cost for a CRNA is 15% less than the cost of education for anesthesiologists. Total pre-anesthesia and anesthesia graduate education costs for CRNA is approximately $161,000 as compared with $1 million for anesthesiologists. Also, anesthesiologist training requires more time and commitment. So how does this impact society? It will cost society less to expand CRNA education programs versus anesthesiologist education programs and produce a workforce faster. Without autonomy, there may be a disproportionate workforce and therefore underutilization of providers or a paucity of providers when compared to demand. This is one of the strengths supporting the argument of nurse anesthesia autonomy. Medicare also plays an important role in the economic costs of training. Hospitals receive financial compensation for Medicare for each physician, resident, and CRNA trained. Although Medicare will only reimburse 50% for CRNA trainees versus 100% for physician trainees, this discrepancy is one of the threats facing nurse anesthesia autonomy and can unfairly shift hospital preference to choose physician training over CRNA training. In conclusion, when evaluating the fiscal implications of CRNA autonomy, independent CRNA practice is the most cost-effective. The employment cost of nurse anesthetists is significantly lower and as such can provide a larger workforce. Furthermore, in rural areas, the cost-effectiveness of an independent CRNA practice model is the only model that will allow for affordable health care. Autonomous CRNAs are more cost-effective to train and will provide a larger workforce for anesthesia care. Society will benefit from the decreased financial burden that autonomous CRNA practice provides. This is a significant strength in the argument for nurse anesthesia autonomy.
Supervision of nurse anesthetists ranged back to the Dagmar Nelson trials in the 1930s that established our practice of either direct or understood supervision by a physician. So therefore, we were not practicing medicine. And that physician could either be a anesthesiologist, which in a lot of places it is, either directly present for induction of, say, an ASA3 patient, or one that is on staff and just has an understood practice agreement with the nurse anesthetist. Or in many rural states, there is no anesthesiologist, but it's a physician who's technically the figurehead and supervising the nurse anesthetist. However, in modern practices, many surgeons, if not all of them, defer to the expertise of the nurse anesthetist in the realm of anesthesia, not only because A, they're not trained in it, and B, they don't want to be associated with legal liability. And noting this problem, or actually further compounding this problem, was the Center for Medicare and Medicaid Services, CMS, that prevented reimbursement for nurse anesthesia providers who did not have the direct supervision by physicians. Now, noting this problem, CMS decided to let the states decide whether or not they wanted to continue with this archaic model of physician supervision in figurehead only. And many of the rural states, 14 of them originally, opted out of this reimbursement rule from CMS, so they no longer required any physician monitoring. And this caused a huge consternation between the Society of Anesthesiologists and the AANA, and it actually presented a very unique experiment, if you will, to see whether or not nurse anesthetists provided as safe care or safer care than anesthesiologists. The results from looking at mortality and complication rates in the opt-out states and the non-opt-out states clearly demonstrate that there is absolutely no difference between the complication rates between anesthesiologists and nurse anesthetists practicing independently. In fact, in relative to the solo practice of anesthesiologists versus nurse anesthetists, they actually had a lower instance of complication rates, slightly lower than for the nurse anesthetist than anesthesiologists, which basically you can infer that from a standpoint of safety, there is absolutely zero difference between nurse anesthetists and anesthesiologists.
Throughout this presentation, we have outlined for you several of the strengths and opportunities that support autonomy of nurse anesthesia practice, and several of the threats or weaknesses that nurse anesthesia practice needs to overcome. This now concludes our presentation. Please reply to the discussion questions posted in Blackboard. Thank you.